Good morning, ladies and gentlemen. Good morning, ladies and gentlemen. Today we'll talk about a good topic, um, and it is about assess, classify, treat, and follow up and counsel for diarrhea in a specific age group, which is would be between the 2 months until 5 years of age. And um, um, this complaint is very common. The diarrhea is one of the very common complaints presented in the primary healthcare in this age group. So, and have many catastrophic event, either mortality or morbidity from the diarrhea. Nowadays, it's lesser than before in our region due to many reasons. We increasing the standard of hygiene and also there is a vaccination for the rotavirus that reduces this um, complaint to this age specific. And most common cause of the mortality from diarrhea is due to dehydration. So we should master how to manage and deal with dehydrations. And our topic, we should assess and classify the sick child complaining for diarrhea and to treat the child complaining of diarrhea, counsel the mother for diarrhea, give follow-up care for diarrhea. As usually, we have a specific way and steps for an IMCI steps. Firstly, we have assess and classify the sick child. Secondly, we treat the child, and then counsel the mother and give follow-up care. Overall picture of management child complaining of diarrhea. Firstly, after the child and caregivers passing their reception, they should go to the triage corner and seen by triage nurse to look for general danger signs. Just want to remind you about this. If the child is not able to drink or breastfeed, if the child is vomiting everything and the child has had a convulsion or is convulsing now, or the child is lethargic or unconscious. So if they have one of these, we should classify him as have a very severe disease, and they should be referred to the treatment room where should have a quick management assessment and interventions by giving, for example, if he is convulsing, giving diazepam or giving sugars. If you think about low sugars and the warming child, giving fluid, it's indicated, and oxygen is indicated. And have a quick assessment to look if there's other complaints than the diarrhea, which have need further assessment, and then refer urgently to the hospital. If the child didn't have any general danger sign complaining of diarrhea, we should look for specific danger signs. Which one of these is look for sunken eye? Sunken eye. The eyes of the child who is dehydrated may look sunken, deciding if you think that the child has a sunken eye. This then ask the mother if she thinks that her child eyes looks unusual. Her opinion helps you confirm that the child's eyes are sunken. You should remember that there is many children looks have a sunken eye, and there is unusual eyes, and there is others who are looks most of the time on sunken eye, even if dehydrated. So you should be wise about it. But there is another category of children who have severe malnutrition. Children, as who, for example, the marasmus children, they look sunken, even if child is not dehydrated. And even though sunken eye is less reliable or not visible in worsted children, we still use the science of classifying the child for dehydration. This is a good picture helping use to look for a sunken eye. As you see here in the first one on the left side, you see the child is lethargic, looks lethargic and have a clear sunken eye. In the right picture, you can see how the child is irritable, but also you can note that the child has a sunken eye. Then we should pinching the skin for on the abdomen, and we should look if it goes back immediately or very slowly or slowly. About very slowly, that means longer than 2 seconds. If it's between immediately and 2 seconds, we call this slowly. So that means return less than 2 seconds, but not immediately. So this category is very important to help you in the classification of dehydration and acute diarrhea. Um, Second one, as I mentioned before, you should know even in the child with marismas, the skin may goes back slowly, even if the child not dehydrated. In the overweight child or child with edema, the skin may goes back immediately, even if the child dehydrated. Even though the skin pinch is less reliable in these children, still use it to classify the child for dehydration. So we can use it in this classification. And then look to the skin pinch. You usually do it perpendicular to the skin lines, as we know, crystalline, skin crystallines, and then just pinch it for a little bit up the abdomen, and then release. Me, um, if it goes immediately, it's good. If it goes slowly, then there's some dehydration. Very slowly, one of the causes of severe dehydration. Please don't forget to ask about the blood and stool and look for it. The blood and stool, usually you can see in the blood as streaks of blood or even black stool. So if the child have a specific danger signs or, or general danger signs, as mentioned before, we should the child refer to the treatment room, then have a proper management. So in this category, you can know that if the child have one of two of these, if they are lethargic or conscious or sunken eye or not able to drink or drinking poorly or skin pinch goes back very slowly, that we assess him as severe dehydration. Don't forget there is what we call persistent diarrhea. Persistent diarrhea is that have a diarrhea for 14 days or more. So if some children have a diarrhea duration 14 days or more, that means have go to another classification, not a 14 diarrhea. And if those who are have a persistent diarrhea have some or severe dehydration, they get classified as a severe persistent diarrhea. Don't forget that the blood and stool is classified as blood and stool and should be referred to the hospital. If there is no specific or general danger signs, the child can be waiting in the waiting area until seen by the direct physician in examination room. And by this, the categories, the children will have either acute diarrhea with some dehydration or persistent diarrhea with no dehydration, or the child having an acute diarrhea with no dehydration. So this is just a wrap-up or overview picture of diarrhea. Now we will go specifically in detail. We assess for a diarrhea. First step, we should ask if the child has a diarrhea. Usually the diarrhea in our category is classified as a change in the bowel motions for the children, or more than 3 stools per day. So if you have one of these, the child has diarrhea. Um, um, and then if the child has diarrhea, we should assess for dehydration, persistent diarrhea, and blood stool. Second question, we ask for how long the diarrhea. If the diarrhea is lasting for 10 days or more, the child has a persistent diarrhea. And after that, we should ask if there is blood and stool. If there is a blood and stool, we classify him as blood and stool, and the child needs to have um, at any time during the episodes of diarrhea. So maybe once or even for every loose motions. About what we should look for, we should look for the child's general condition. Firstly, we should look if the child has lethargic or conscious, and we have a good description of this in the presentation of danger signs. And after that, we should assess for if the child is restless and irritable. The child has the signs of restless or irritable if the child is restless and irritable at all the time, or every time he is touched or handled. The infant or the child is calm when breastfed, but again restless and irritable when he stops breastfeeding. He has the signs of restless and irritable. Many children are upset just because they are in the clinic. Usually, these children can be consoled or calmed. They don't have a sign of restless or irritable. Look for sunken eye, as we mentioned before, and this is just a reminder. And do a skin pinch for abdomen and look how it goes back. So just remind you that the skin pinch have three possibilities: if it's returning very slowly or immediately. And by this way, you can decide to put which classification. And then you should look if there is a blood in stool, rather than asking. As I mentioned before, you can see a streaks of blood, or you can see a black stool. Offers the child fluid. This is one of the things which is very important to assess the child's drinking, being able to drink or poorly drinking or drinking eagerly or thirsty. So ask the mother to offer the child some water in a cup of water or a spoon. Watch the child drink. A child is not able to drink if he or she is not able to suck or swallow when offered the drink. Child may not able to drink because he or she is lethargic or unconscious. Child is drinking poorly. If the child is weak and cannot drink without help, he or she may be able to swallow only if a fluid is put in his or her mouth. A child has the signs of drinking eagerly thirsty if it is clear that the child won't drink. Look to see if the child's reaching out for a cup or spoon when he offered him or her water. When the water is taken away, see if the child is unhappy because he or she wants to drink more. If the child takes a drink only when encouragement and doesn't want to drink more, he or she doesn't have any signs of drinking eagerly or thirsty. So all of these should be assessed first, and then after that we classify the diarrhea. And according to classification, we have three categories. Either the child have an acute diarrhea and then we assess the dehydration status. Acute diarrhea, that means the child have a duration of diarrhea less than 14 days. Or either the child have a persistent diarrhea, which the child have um, diarrhea for 14 days or more, and we assess the hydration status, or either the child have a blood in stool. So either one, we should have possibilities for the hydration status. So the possibilities of the classification will be either acute diarrhea with severe dehydration, or persistent diarrhea with dehydration, or blood in stool, or acute diarrhea with some dehydration, or persistent diarrhea without dehydration, or acute diarrhea with no dehydration. So all of these are possibility. About persistent diarrhea with dehydration, we classify him as severe persistent diarrhea. We should, at the time of treatment for diarrhea children, as we said that The most common management for treatment the corner is the fluid management in addition to the zinc. But you should remember that we have a specific plan for specific classification of dehydration. If the child has severe dehydration, we have a plan C. If the child has some dehydration, we have a plan B. If the child has no dehydration, we have a plan A. So we will start um, with zinc supplementation. The zinc supplementation, as I mentioned, is very important for the children. Why we need to give it? Firstly, it's helping to reduce the severity and duration of diarrhea. In addition to that, preventing recurrence of the diarrhea. And all of these very important to remember. So the zinc helping in treatment and prevention together. Zinc is it's one of the elements that's important to fighting against diarrhea. Zinc supplementation doses. We have a specific dose, fixed doses. If the age group between 2 months until 6 months, the dose would be 10 milligram. If the age group 6 months to 5 years, the dose will be 20 milligram, and both once daily for 14 days. So there's different concentration, and in syrup we have two concentrations. Syrup, one 10 milligram per 5 mil, and another 20 milligram per 5 mil. So we have different doses in mil, as demonstrated in this table. About the tablet, we have fixed doses. It's 20 milligram for children. So we at the age between 2 months up to 6 months, we give them half a dose or half a tablet, and between the age of 6 months to 5 years, we give one tablet daily. Just to remind you that you should inform the mother we don't give higher doses because there's some risk for toxicity. You just give the proper dose. Fluid supplementation, we start with treatment for diarrhea at home, which is plan A. We concern and focus on the four component of rules for home treatment. One of it is just give an extra fluid, give a zinc supplement, continue feeding, and when to return immediately. About give extra fluid, we should tell the mother breastfeed frequently for longer duration. And the child, if it's exclusive breastfeed, we can give an ORS or clean water in addition to the breast milk. If the child is not exclusive breastfeed, we can give one or more of the following ORS or food-based fluids such as soups, rice water, and yogurt drink. And all is very helpful to giving a fluid and giving some nutrients that's very important to fight against dehydration and low calorie. It is especially important to give an ORS at home when the child has been treated with plan B or plan C during the visit, and the child cannot return to the clinic if the diarrhea gets worse. About teaching the mother in the triage corner or even in the ORS corner to give the mother 2 packs of ORS and show her how to use it. And also you remind the mother that every have additional fluid to be taken for every loose motions. And there is a specific doses if the age group between up to 2 years. So we can give between 50 and 100 ml after each loose stool. Or if the age group between 2 years until more, we give 100 to 200 ml after each loose stool. And that helping to fight against dehydration. Tell the mother that we should give it frequent and small sips from a cup, not from the bottle. And if the child vomit, we're just waiting for 10 minutes and then continue, but more slowly. We continue to giving an extra fluid until diarrhea stop. So it's not a work for a day. We should continue to give the fluid until the diarrhea stop. As we mentioned about the zinc, there is the doses and should be continued for 14 days, even the diarrhea if stopped. So should continue, and that's why this question is very important, and you should clarify to the caregiver or the mother about the importance of the zinc, and we mentioned that the importance of it. It's helping to reduce the severity and duration of diarrhea, in addition to that, to prevent recurrence of diarrhea. And we should continue feeding exclusive breastfeeding in age less than 6 months, and return till her going to return, and that will discuss it later in detail. Now we go to the plan B. Plan B is an option, should be done for child who, when we assess it at the clinic, the child have some dehydration. So he acute diarrhea with some dehydration, and should be this dehydration be managed in your clinic before goes at home. So we have about in your clinic, we should give an ORS for at least 4 hours, over 4 hours period, and look to manage the to help to changing the acute diarrhea from some dehydration to no dehydration. This one can be done by giving an ORS fluid about calculating the dose 75 ml per kg in duration of 4 hours. So you just calculate it and give these doses in 4-hour duration. We have this table can help you to figure out the amount of fluid which should be given in specific durations. So the child wants more, you should give him more. For infants below 6 months who are not breastfed, also give 100, 200 ml clean water during this period. So even though frequent breastfeeding or not breastfeeding, you should also give 100, 200 clean water during this period. The other management nearly the same, but show the mother how to give an ORS. It's very important, and we said we do it in ORS corner or in treatment room. In our clinic, we do it in the treatment room. Don't have a specific place for an ORS corner. Give a frequent small sips from the cups, and if the child vomits, just waiting for 10 minutes and then continue but slowly. And we continue breastfeeding whenever the child wants. After 4 hours, we should assess the child again and look if the child have some dehydration or severe or no dehydration. So we should assess the dehydration status and select appropriate plan according to the assessment and begin feeding the child in the clinic. If the mothers must leave before completing the management, you should show her that the proper ORS solution at home, how to prepare it, because this is the tricky part. We should help her to do it properly. Otherwise, maybe we'll have some worse situations. Show her how much ORS to give to finish the 4 hours treatment at home, and give her instruction how to prepare salts and sugar solution for use at home, and explain the 4 rules of home treatment, which is mentioned in Plan A. I just want to remind you in summary, we give an extra fluid, give zinc, and continue feeding, plus when advise her when to return. Now, maybe a child has severe dehydration, And we should follow the plan C. The plan C, it's very important to be done quickly, and you should have questions to be asked to know your possibility and what you can do. The first question, can you give an IV fluid immediately? If yes, you should start giving an IV fluid um, in uh, in 6 hours duration for infant and in 3 hour duration for the children. So the doses which should be given, we should preferable to give 100 ml per kg ring lactate solutions. If it's not present, we can, or not available, we can use a normal saline. But I want to remind you about how to give it. In infancy, which is the age below 12 months, we should give in the first 30 ml per kg in the first hour. And then in the second 5 hours, we should give 70 ml per kg. In children, we should give 30 ml per kg in half an hour, and then 70 ml per kg in 2.5 hours. So we should reassess the child every 1 to 2 hours. If dehydration status is not improved, give an IV drip more rapidly, but should not too rapid. I'll also give an ORS solution if 5 ml per kg per hour, as soon the child can drink. Usually between 3 to 4 hours for infancy and 1 to 2 hours for children. And after 6 hours for infancy and 3 hours for children, we classify dehydration again, then choose the appropriate plan, either plan A or B or C, and to continue the treatment. But if you cannot offer an IV fluid, what we can do? We should ask ourselves, is the IV treatment available nearby? So, for example, you are near to the place of hospital and the emergency department in the logistic can reaching the treatment room in less than 30 minutes. So just refer urgently to the hospital for IV treatment. And during the road, you can advise the caregivers to give the child drinks provided by ORS solutions and give it frequently, give sips of water, or continue to breastfeed. In addition to that, maybe be using a nasogastric tube for helping that child. But if not, if you cannot offer this option, you ask yourself, are you trained to do an NGT tube? If you are, you start rehydrated by the tube or mouth with the ORS solutions. We give 20 ml per kg for 6 hours, and the total dosage is 120 ml per kg. You just reassess the child every 1 to 2 hours while waiting for transfer. If there is a repeated vomiting or abdominal distension, just give the fluid slowly. If the dehydration status is not improved after 3 hours, send the child for IV therapy. After 6 hours, reassess the child, classify dehydration, then choose the appropriate plan, either A, B, or C. Then we should ask ourselves, can the child drink? If yes, okay. So that's. But if no, we just refer him urgently to hospital for IV or NGT treatment to give an IV fluid medications. So this is the plans of treatment of dehydration, either giving an IV fluid, giving a fluid either by plan A, B, or C, or giving a zinc supplement. Now we're going to the follow-up care for diarrhea. So about acute diarrhea, there is no follow-up care for acute diarrhea, fixed follow-up care. Only for if not improved, they can bring them again after 5 days. For persistent diarrhea, we have a fixed follow-up care after 5 days, and we should ask if the diarrhea is stopped or has many loose stools in the child have per day. Our questions is we have many possibilities, but Or one of these possibilities, if the child has not stopped, and that means the child is still having three or more loose stools per day, do a full assessment for the child, treat for dehydration if present, and then refer to the hospital. But if the diarrhea has stopped or the child has less than three loose stools per day, tell the mother to follow a usual feeding recommendation for the child age. In counseling the mother for diarrhea, we have a safety net, and as mentioned, about the safety net for diarrhea, we should advise the mother when to return immediately if the child has one of these signs, any general dengue signs, lost blood and stool, drinking poorly, or become sicker or develop fever. About home care, I was just repeating, mentioned that we should giving a breastfeed more frequent and longer duration. That child should take a breast milk substitute, increase the amount of giving fluid and milk, and giving a soups, rice water, rehydrate drink, clean water more frequently. In promotion, if the child have the acute diarrhea with no dehydration, we should advise her for the next well-child visits if and immunization are proper. But also this time it's helpful for remind the caregivers about the importance of hand hygiene. Most of the time, diarrhea derived from the infections from improper hand hygiene. So frequent hand hygiene is very important, helping to reduce the diarrhea recurrency in this specific age group. Thank you for participation. I hope you enjoy this presentation and I hope we will see each other again very soon. Thank you.